Although you can see the conclusion we eventually came to, I'd like to present this case to you as it came to us, which is something of a medical mystery. The patient was a 44-year-old man with treatment-resistant AIDS, diligently adherent to heart therapy, who presented to the UC Davis Emergency Department with several days of nausea, vomiting, diarrhea, and recurrent nocturnal fever. On exam, he was hypotensive, tachycardic, and febrile, and so was admitted for treatment of possible sepsis. Of note, he had come to the hospital twice in the previous year with similar symptoms, and so by the time he came to us, he was already on treatment for presumptive Mycobacterium avium complex, or MAC. In his first week, he continued to have fevers and diarrhea. A CT scan showed scant lymphadenopathy with nodes that were too small for biopsy. LFTs were elevated in a cholestatic pattern, and this was eventually attributed to the hepatotoxic effect of his MAC therapy, and this was discontinued. He had recurrent pancytopenia over that first week, requiring multiple blood transfusions, and this got us thinking about causes of marrow suppression, maybe a different infection, or a malignancy. In the second week, he continued to do poorly. In spite of antibiotic therapy, he continued to have fevers, and a repeat CT scan showed rapidly growing splenic calcifications, which you can see here. Because he lived in Pennsylvania, we thought maybe disseminated histoplasmosis and gave him a single dose of amphotericin B. At the same time, we obtained a bone marrow biopsy, and this showed caseating granulomas and large atypical-looking binucleated cells, which once stained were found to be Reed-Sternberg cells, and this gave us a diagnosis of Hodgkin's lymphoma. Further testing gave us elevated soluble IL-2 and ferritin levels, which in addition to his fevers, hepatosplenomegaly, and pancytopenia, gave us a second diagnosis of hemophagocytic lymphohistiocytosis, or HLH. The patient was started on Solumedrol and vincristine for the Hodgkin's lymphoma and etoposide for the HLH, and did show initial improvement on this regimen. However, he began to decompensate, had to be taken to the ICU, and eventually succumbed to his illness. Hemophagocytic lymphohistiocytosis, or HLH, is a rare and aggressive condition caused by immune system overactivation. It has, although rarely, been found in the literature to be both a potential trigger and early clinical manifestation of Hodgkin's lymphoma, which is an AIDS-associated malignancy. What we learned from this case is that HLH is difficult to diagnose. It lacks a confirmatory test, and its symptoms are nonspecific, and so for that reason it wasn't initially suspected in this patient. Furthermore, he didn't have hemophagocytes on his bone marrow biopsy, but this is neither a necessary nor a sufficient criterion for diagnosis. Additionally, some papers are starting to show that hemophagocytosis may be more readily appreciable on serial versus individual bone marrow biopsy. Another special thing about this case was the diagnosis of Hodgkin's lymphoma on bone marrow biopsy. This is unusual. Usually you see the constitutional symptoms, the cervical lymphadenopathy, but in him his lymphadenopathy was really scant, and the additional feature of the diarrhea made us think more infectious causes. In summary, hemophagocytic lymphohistiocytosis, or HLH, can be observed with Hodgkin's lymphoma in our AIDS patients, and so should be considered in our immune-compromised patients who present with recurrent fever, hepatosplenomegaly, and pancytopenia.